So I hope everyone can see me and hear me. My name is Karen Perry. I'm the manager of information services at the library, and I manage the library's Just for the Health of It Health Literacy Initiative. I'm so honored to have Dr. James Salwitz with us tonight on this very important topic of brain cancer. Dr. Salwitz is a medical oncologist and hematologist with Astra Cancer Care here in East Brunswick. He has nearly 36 years of experience in his profession as of this January. So we are really honored to have the best of the best here with us and to hear Dr. Salwitz speak about the important topic of brain cancer, because this is such a serious and interesting topic, and he brings so much of lifetime experience to helping people understand the condition and treating people. So without any further ado, I would like to introduce Dr. James Salwitz. Thank you, Dr. Salwitz.
Thank you, Karen. Thank you so much. So we have an intimate group tonight. It's too bad we just can't be all sitting around a table somewhere. It would be a lot of fun, to have that conversation with just a small group about this. But I think this is an interesting topic. I do think it's a little bit macabre that we're doing brain tumors just a couple of days before Halloween, because they're both really scary topics, So, but I think it's still an important one. This is kind of a hard topic sometimes to talk about, I think, particularly in a general conversation, because this is a bad disease. And we have a long way to go in this disease. While there's a lot of interesting research, there's breakthroughs that are happening. There's also a lot of, it's also not a disease that much of the time has a good prognosis. So one thing I would suggest, hearing a discussion such as this evening, that you look at it as kind of a broad education, not only about, brain tumors, but about oncology, and cancer, in general. And that, I think that may be an approach that, that may be of help to kind of thinking about, this disease as we go through this, this evening. As Kara was saying, I'm a medical oncologist in practice with Astera. Astera is the largest private practice oncology group in the state. We have medical oncology, radio-oncology, breast surgery, some primary care. And we believe talks like this are important because the more the more you're empowered, the more you understand what is happening. When things happen to you, to your family, etc., the better you are to understand, what's going on. We're gigantic believers in research. You'll hear me say multiple times during this talk tonight about research initiatives and being involved with them. It's important that we get involved in research early on. Brain tumors are not just one disease. So I'll get that feeling a little bit tonight. There are actually several different diseases, and I'll we're going to walk through that. But again, while much of what this is not like it's been one of the incredible things we're seeing with immunotherapy now and molecular therapy, although those may apply, the incredible breakthroughs. This is still a disease we have a long way to go. But if you understand this disease or some technology around it, maybe understand a little bit more about cancer in general, and of course this disease itself. So thinking along that line, just some quick terms, cancer, I think people confuse what cancer itself is. Cancer is what happened when growth gets out of control. There are genes in every cell of the body that control growth. And when they get stuck in the on position, if you will, they get damaged because of time, age, genetics, inheritance, chemicals, smoking. That's when cancers start to grow. The difference between a benign and malignant tumor is that malignant tumors have the ability to invade into the tissues around them, and then have the ability to spread sometimes around them. But having said that, tumors that start in the brain almost never spread from the brain. On the other hand, tumors can spread to the brain, and those are still called and treated like where they came from. So if a breast cancer goes to the brain, that's still breast cancer just in the brain. It's what we say is metastatic. While a tumor that starts in the brain is a primary tumor, and again, is very unlikely to ever leave the brain. I put terminology, the brain, now I hope all of you know exactly or more or less where the brain is. The heart, the soul is in the brain, not on the heart, if you will. I hope you know that. Just a quick, surgery is the actual use of various sorts of cutting tools to actually remove something. Radiosurgery is the concept of intense radiation therapy given to a small area to destroy that. I think that technology is different. Radiation therapy comes in multiple different types. When we talk about the brain, we're talking about computer augmented guided radiation therapy, so-called stereotactic or cyberknife, which can aim radiation to a very small area. Or we're talking about whole brain radiation therapy, that you can radiate the entire brain at one time, which is sometimes or often necessary in brain tumors. And then there's proton beam. Proton beam is the use of particles as opposed to a beam of radiation. It's microscopic, super microscopic particles, which the particles fly through, and then when they get to a tissue, the particles actually explode. It's called spilate. They blow up, and this can give you incredible accuracy as well as intense radiation therapy to a deep part of the body with tremendous accuracy. You can radiate the front part of the eye without radiating the back part of the eye using proton beam. Chemotherapy is the use of drugs that actually kill cancers directly. Immunotherapies are the use of drugs that stimulate the immune system to kill cancer. Most cancer patients have normal immune systems. The problem is not that the immune system doesn't see the cancer. The problem is that the immune system doesn't even know the cancer is there. And immune therapy is supposed to fix that. And then more and more, we're using molecular markers, genetic markers, to both understand how cancers grow. Like I said before, every cancer is caused because of genes that are stuck in the on position. And if we know what those genes are, we can at least understand something about the cancer, and more we can turn those genes off. I put steroids here. Steroids are used a lot in brain tumors because of the inflammation, and steroids take down swelling. We'll talk about that again. MRI versus CT. When you talk about the brain, you're almost always talking about MRIs. It is using magnetism instead of radiation, and they give much more detailed pictures of nerve structures, inflammation, etc., more than CAT scans. CAT scans are excellent for certain situations, particularly strokes, bleeding, but for brain tumors and stuff, we use MRIs a lot. And then I put the bottom, when you talk about some of these really awful diseases, you have to just, I think a reality check for all of us is important. And in some situations, we're talking about cure. But often we're talking about palliation, which is quality of life, sometimes longer life, pain-free life, life doing the things you want. And palliative medicine does need to be distinguished from hospice medicine. Hospice medicine, is just medicine focused on quality of life at the end of life when you're no longer considering treating that. When we talk about risks for tumors of the brain, now in this case, these risks are primary tumors of the brain, tumors that start in the brain. The reality is, most of the time, there's not a reason that we know that these occur. About the only well-proven general cause for brain tumors is ionizing radiation. And by that, I mean nuclear weapon level radiation or radiation therapy nuclear radiation. Children who have had brain radiation for tumors usually have an increased risk of brain tumors later in life. People that were at Nagasaki and Hiroshima had very high levels of brain tumors. But as far as general causes, that kind of that's not the only well-proven cause. Now, there are certain uncommon genetic syndromes that increase the risk of brain tumors, but by far, most people with brain tumors don't have one of those genetic syndromes. Trauma, there's a debate whether certain traumas at certain times can cause increased tumor, but that's never well been proven. There's this debate of whether certain infections may increase brain tumors, but weirdly, there are some infections that seem to protect against brain tumors. If you had chickenpox as a child, you're a little bit less likely to get a brain tumor, and no one has any idea whether it is. Smoking does not affect brain tumors. Alcohol does lots of horrible things like smoking, but does not affect brain tumors. And at this point, there are no proven environmental chemicals. So I think many of us think that there is it's really possible there are environmental chemicals out there that cause and increase these tumors. They just have not been identified, as yet. So this is a particularly scary slide. Because it starts to tell us what some of the symptoms, are of this disease and why. There are no nerves inside the brain. You can do brain surgery and operate with someone awake and they don't feel anything. The brain has no nerves in. So, but why do we get symptoms? And people can get headaches. There's a classic headache that you wake up in the morning, goes away through the day, but the classic headache is probably rare, and we think the headaches are probably more random and waxing, waning and stuff. You can have seizures. Interesting enough, a seizure as the first symptom of brain tumor is a good prognostic sign. It usually means the tumors are smaller. People can get headache and vomiting and stuff. That can happen. And then change in neurological changes, speech changes, your speech, or just sensory changes, or just how we function, confusion and things like that. But why do we get these symptoms at all? And there's three reasons why we get these symptoms. One is damage directly of the tumor of the brain. Secondly is pressure. If you hit your knee and it swells up, but it just swells up, makes your pants tight. If you have an injury inside the brain, say a brain tumor, there's swelling, but the brain is encased in bone. So there's nowhere for that pressure to go. So you simply build up pressure inside the brain, which can cause, a lot of symptomatology. And then there can be direct, there can be the damage of the electrical function of the brain, because the brain is an electrical organ, and that can lead to seizures or other things. As you look at your slides here, you start in the upper left. So the A through E on the upper left, this is actually a breast cancer that's spread to the brain. And you can see it in A, where the yellow star is, the arrows, and then E, this is an MRI, which is a different phase of the MRI showing it differently. You can see where the tumor is. So you can see that takes a lot of area, and that could cause damage in that area and cause a symptom, there. But if you look at B and C, you see arrows that I put there, pointing to this white area. That white area is not cancer. That white area is swelling that occurs around it. So you can see you can build up pressure because of all that swelling around that tumor. On the other hand, that's a breast cancer. On the other hand, A through C, this where the star is, which is very hard to see, that is a high-grade brain tumor. It's a cancer started in the brain, a glioblastoma. And so you can very faintly see a little bit right next to the star is. But what is so scary about this is you look at the other two phases where I have the double arrows, you see kind of a white blush where I've put those double arrows. That white blush is cancer. It is spread through the brain. It's not swelling. There may be swelling here also, but it is spread through the brain and mixed with the brain. So this has caused damage in here. I should have said this to start. You're looking at MRIs here. You're looking from the top down. Eyes are in the front, back of the brain's in the front. The black area is in the middle of the ventricles where there's fluid there. So this is why you can get symptoms, of this, all. Now, symptoms like this, I can be pretty similar to other diseases of the brain, bleeding into the brain, strokes, infections. These can also cause symptoms like this. And when the person first gets a symptom, that's what the doctor is looking for, exactly where, which of these diseases. Is this a tumor, or is something going on? So these are the types of primary brain tumors. Again, we'll come back later to metastatic cancers, cancers spread to the brain. These are primary brain tumors that have started in the brain. And if you look at this table on your left, the graph on the left, you can see that almost all brain tumors increase as we age. The differences are right at the bottom. You see medulloblastoma, embryonal peanut, and the pilocytic astrocytoma. Those are cancers of infants and of young children. And you see that those have gone down in rate, but almost all the other ones have gone up in rate and then peak somewhere around age 64. The most common of the primary brain tumors, as you see at the top, is the meningioma. Now, meningiomas are a benign tumor. All right, they grow, but they can't invade, and they could not potentially even spread. And they grow very, very slowly, and they're benign. But unfortunately, the cancer just below that frequency is the glioblastoma, which is the most common aggressive brain tumor, malignant brain tumor, and is it's very hard to treat, as we'll discuss. And unfortunately, it is the most common right after this. The tumor on the right you're looking at is a glioblastoma. Again, you can see the blush of the tumor where the arrow's pointed in B, and this gray area around it, which is some mixture of swelling and of pressure and tumor. Now, meningiomas, are the most common primary brain tumor. They very often don't need to be treated. They can grow very slowly. We think actually that most meningiomas, we never find them. They grow their whole lives, and they don't get a routine MRI or CT or find it. But they can cause, they can cause, real problems. This is a meningioma. I mean, this is a benign brain tumor, but it is not small. Now, if you look at it, your eyes kind of thinking of the previous things, you can see how it's a clear edge, around it and stuff. There's no swelling around it, particularly. This has grown very slowly over, slowly over many years. Maybe since this person, was, in their teens, and they're, now they're, in their early 60s. But it is, but it is a significant tumor. This patient had this tumor completely removed, and was fine, and had an excellent recovery from that, from that therapy. So the so what brain tumors are, malignant brain tumors are all falling under the category called gliomas. That's the broad tumor. Glioblastoma is one type of brain tumor. Gliomas are from glial tissue, which is brain tissue, and they're named from the cell from which they started to grow. So a glial cell gives you a glioblastoma, an astrocyte causes an astrocytoma, et cetera, et cetera. And they have a pattern, of growth based on how they started, and where this, the cell they started from. Again, the most common with a glioblastoma, but these other tumors, are seen not rarely. And each of these tumors does behave a little bit differently. Now, when a tumor like this is discovered, it's generally categorized first by imaging. What's this pattern? How is it spreading? How is it invading? Where is it in the brain? And again, that goes back to the question of, is this a brain tumor? Because it can be, a stroke can look like this, bleeding can look like this, some other conditions, and infection can look like this. I mean, not uncommonly, a surgeon will say, oh, you had a brain tumor, go in, and it turns out it was, an abscess, so basically a boil of the brain. So you first look at imaging, where it is, etc. Now, if a patient goes to surgery, then you're looking at the histology, the physical structure, what it looks like under the microscope. And these things have, a particular structure. Now, neuropathology is a super subspecialty of medicine, and not all hospitals have neuropathologists on staff. In fact, most don't. And a lot of times these labs will be sent out to a centralized, a lab or something that does a lot of this kind of work, just to really understand the difference between these tumors, and their structure. More and more, as I said earlier, we look at the genetics of a cancer, what genes are driving that cancer to grow, or what genes were supposed to stop it from growing and that were malfunction. And there are three main gene types that we look at, in these brain tumors, and that's the gene type. These are genes on the left, the IDH, the CDKN2AB, and the MGMT. These are genes that are found in the tumors, and we look at them to understand how they'll grow, to get some decisions about treatment, but also for the, to define the, the pathology. So, for example, glioblastomas, by definition, are IDH non-mutant. If you're mutant, then it's a high-grade astrocytoma, and then you have to subdivide that. So so you have the genetic structure as well as the physical structure, as the microscopy structure, to understand, these cancers. Going back to my comment earlier about learning in general about oncology, from this kind of thing, this is oncology everywhere now. When we look at breast tumors, we look at lung tumors, we look at bladder tumors, we look at, colon cancers, we're doing, any of them, we're doing the same kind of thing. The genetics are incredibly important to understand what is driving these cells to grow, and then more and more to give us clues of how to treat them. So it's but it is critical, particularly in these brain tissues. Tumors like this are graded in a 1 to 4, 2 to 4. 1, they're benign lesions and stuff. It's not part of this categorization. It's a little bit weird that way. And 4 is the worst, and that's a GBM glioblastoma multiforme, which unfortunately is the most common of primary brain tumor. And you can see those really depressing numbers at the bottom. I mean, that's 48% of primary brain tumors. Everything else is a mix. Significantly more than 10,000 deaths per year. The average survival is 14.6 months. Now, there are we have in our practice GBM patients that are alive multiple years beyond that. There are several GBM patients in the United States that are more than 25 years old. And when you look at that 14.6, you're looking at people that die, that are 90 years old, have no therapy, and die in 2 months, and your other patients that are alive 2 and 3 years later. So 14.6 is not a hard number, but it is a really depressing number still, with this tumor. And the average age in the United States for this disease is 64 years old. So how do we treat it? Well, first, you're staging it. And in this case, I mean, looking at the MRI of the brain to see where it is. If this tumor is in an isolated area of the brain that doesn't have, there's a lot of duplicated function. Like I showed that a meningioma patient, say, how can you remove that? Well, if you look at it, it was frontal and isolated, and you can remove it and everything else can move forward. But if the tumor is deep in the center of the brain, if it's in the motor strip, it's in a real critical area, staging it with MRI becomes really important to deciding, can you operate on this disease at all? And very, very importantly, you immediately rule out other cancers somewhere else in the body because, well, we'll get back to later on, metastatic cancer spread to the brain can mimic this. And you don't want to be surprised doing surgery if you think it's a primary brain tumor and it's a metastatic tumor that you miss, somewhere else. Although you may operate on those tumors, which we'll discuss being way fine. I put this in early, and when you're dealing with a disease that can be as devastating as this, I think it is important that family and doctor and the entire team sit back and have a real discussion, early on about whether what they want done, how aggressive they're going to be. The treatment for this is a little complicated. It can be aggressive. It can be, some have significant complications. So I think it's important that families meet and talk, and understand, what is the goal? What are we going to achieve? What is really possible here? As one commits further, into therapy in this disease. And I think those meetings are very important early on. I saw a patient not long ago, who came into a hospital in our area. It was noted to have an aggressive tumor, was having neurosurgery in 2 days. The family didn't know what was going on, et cetera. And I really would have liked, because I saw this patient later on, to have the opportunity to sit down with the family, do you know what you're getting involved in, at this point? It doesn't mean you don't want to operate, but it does mean, or being aggressive, or approach this, but it does mean understanding what you're trying to achieve. You have a disease here that, particularly if you're dealing with glioblastoma multiforme, that is not curable. Now, some of the lower tumors have much longer survivals. They may be curable. You may be able to better surgical sections, better outcomes, but it is important to have these conversations early on, I suggest. And then just going back to a theme that I mentioned earlier, we're a gigantic fan of research, at Estera, and personally, I mean, there's so much to be learned. There's so many ideas that need to be explored, et cetera. And if there's the possibility of being involved, it may at least give you access to something that wasn't, might not be available otherwise, and it's worth at least exploring. When you're dealing with brain tumors, particularly high brain tumors, the more that can be removed, the better. It's just the reality. Maximal resection is the goal. Now you're limited by the fact that you cannot, you can't operate on normal brain tissue itself. You have to, because you're because you start doing damage to the brain. Which limits you, compared to other surgeries. In the colon, you've got a tumor that's halfway up the bowel. You can remove 3 feet of a bowel on either side. It won't matter at all. But in the brain, you can't remove more than you need. So surgery like this is requires extreme expertise. We recommend that anyone starting this kind of surgery do it in an institution that does a lot of the surgery. There's a lot of neural mapping. And because a lot of institutions, the surgeons don't want the patient awake, so they can map, so they can map where the neurological things are. So you can actually put a probe next to where the tumor is and figure out if this has to do with speech and other, or this has to do with visual recognition. What you can do is actually slightly freeze that area and say to the person, can you still read? Can you still talk? Do you recognize this picture? And this requires real expertise, real patience, real time, and the intraoperative monitoring is quite complicated. So if you're treating this disease, for the best possible outcome, it should be done in an institution that does a lot of these surgeries and has this kind of broad support. There are a lot of other surgeries that can be done in most general hospitals. This one, if you're really going to treat maximally, requires, that kind of expertise. After therapy, surgery, then you can review the pathology, and as I discussed before, you learned a lot from looking at these tissues, et cetera. Now, if you decide not to do surgery, then you have to make some guesses about what is happening. Some you can actually do a biopsy sometimes. You just want to get information. about this and get this information. But basically, if you have the pathology, using this information in order to make decisions regarding therapy. Brain tumor therapy, whether or not you have surgery, requires radiation if you're going to treat this in a maximal manner. The type of radiation depends where the tumor was, how much tumor there was, the type of the tumor was, how clear the margins, how aggressive it was. Whole brain radiation is radiating the entire brain. And you could see with that slide I show you, the glioblastoma, where it just showed this white blush, that you can imagine that'd be really impossible to get around surgically, and it's just kind of, it spreads through things. So you can understand why you might do, broad radiation therapy. However, if you're doing a lower grade brain tumor or a small primary brain tumor, then you may just be able to radiate the smaller area. And sometimes you can use protons for very, tight areas of therapy. We do use chemotherapy in this disease. The main chemotherapy we use is the drug temozolomide, known as Temodor, which is a pill. It increases the benefit of radiation therapy. It slows the growth of these tumors. Will occasionally, will shrink some of these tumors, particularly the more aggressive tumors. You may do that. Bevacizumab is used in patients later on, in their course of stuff, and actually destroys microscopic blood vessels that grow into these tumors, and it can slow these tumors down. Lomustine is the chemotherapy used rarely in one or two particular genetic situations. It's not used much anymore in some of the low-grade tumors, but it can be of benefit. We would love to be able to do immunotherapy in this disease. Immunotherapy is a revolution in oncology across multiple cancers. I mean, I have patients with metastatic melanoma spread all over their body that are now in remission for 5 years because of immunotherapy. The problem is the blood-brain barrier. There is no blood in your brain. It's surrounded by spinal fluid. The immune system does not penetrate the brain. Instead, you have the blood-brain barrier, and the immunogens isolate the brain, and that's how it protects the brain. So the immune system, even if you could turn it on, doesn't get into the brain, to attack it. So people are trying to solve this problem, and I'll talk about that in a second. But right now, one of the main problems is that it's not only the immune system doesn't know the cancer is there. The immune system is not generally active in the brain. It doesn't penetrate the brain, and people are trying to figure out how to change that, because the immune system, more and more is our best tool in fighting a wide range of cancers. We use a bunch of different supporting medications for tumors of the brain. We use steroids a lot. You have the swelling thing I talked earlier with pressure. Steroids, generally the drug dexamethasone, are very powerful, but bringing down swelling. And you can really relieve the pressure. And a lot of people, when they have these kind of things, they just come in the hospital, will immediately put them on a steroid and shrink them down and then take them slowly off that. Some people end up being on some steroids for a number of months, hopefully not, but sometimes. And the idea is keeping swelling under control. There is an increased risk and occurrence of blood clots, not in the brain, but in the body, with people with brain tumors. And a lot of brain tumor patients end up on blood thinners because they have blood clots or because we're worried about blood clots. And these are the basic blood thinners that we generally use. Most patients with brain tumors don't have seizures and therefore don't end up on seizure medication. We rarely give seizure medication as a preventative. It's another drug with more side effects. But if they have had seizures, then we have seizure medication. There's some interesting research on diet in brain tumors. There's actually some evidence that ketogenic diets decrease brain tumor growth and may shrink them a little bit. The problem with the ketogenic diet, if any of you people have actually ever tried or thought about doing it, is it's really hard to maintain for a long period of time. But that may be a tool that people are trying to figure out how to use better, because you can do a ketogenic diet for a month or two. After that, you start to feel relatively miserable. This is an ongoing illness. I think it's a pattern that it's important people understand. You have this illness and you're going to have periods of time that things are better, worse, but it requires ongoing continuous care of some sort. It requires either medications, or it requires blood thinners, it requires visits to the doctors, changes in steroids. It may require repeat surgery in a small group of patients. Rarely will it even do repeat radiation in group patients. And so it's just the point being, this is, once you're into this, they're not giant periods of time that are you just, you get a gigantic break. I mean, people's patients that get away and they travel and they're with their families, but they're frequently having to come back and keep a very close eye on this with imaging scans, blood tests, et cetera, et cetera. I put the comment there, pseudoprogression there. Sometimes it can be very hard to tell if you're looking at someone that's had surgery, chemotherapy, radiation, and you're seeing swelling. Are you looking at real tumor or looking at pseudoprogression, which is very hard to tell and can be very frustrating for patients because you're saying, is it worse? I feel worse. The steroids got it better. Was that steroids get it better because it's pseudoprogestion, which is swelling, or is it tumor? It can be hard to tell apart. There's great data saying that people who stay active, whether it's physical therapy, just going for long walks and, being out and around, do better with this disease, prevents blood clots, there are less other complications, and may seem to do something, to help prevent tumor. And then I cycle again back to the concept palliative care not being hospice care, but palliative care being care focused on quality of life, diet, preventing symptoms, dealing with, social and, family issues, through the, course of illness. I think that's important to get involved, early, whatever the course. Obviously, at some point in this disease, in the vast majority of patients, hospice may be reasonable, but that's not, what I'm focusing on with that comment there. Now, it's all really frustrating, somewhat depressing. There is an immense amount of research going on in this disease. It's just, and people are attacking this in all sorts of different ideas. And I put this one slide up. I could have put up 5 slides because it's something that people are very interested in defeating, and we will, based on the breakthroughs in oncology in general over the last few years and other diseases. In the Lancet, within the last couple of months, there was a therapy using, they actually introduced 2 viruses directly into the brain, and one virus caused inflammation of the dental tissues and stuff, and one causes inflammation of the tumor itself. And the idea was to stimulate an immune response, by getting the immune system to attack this. This is what's called a phase 1 study. It was just to see how people did with this, and people actually tolerated this, fairly well. Some early indications that it caused immune response, but they weren't actually looking for that. This is the New England Journal of Medicine just last month had this double drug combination, in gliomas that have a particular gene mutation, not one we normally look at. So it shows we're looking at mutations, and they had a very strong response. It's an unusual gene mutation. Most tumors don't have it, but it's a breakthrough, for those particular things, possibly. Mayo Clinic, is using radioactive yttrium, which is a highly radioactive salt, and they're trying it both by injecting it directly into these tumors of the brain, or by infusing it into the arteries that feed the tumors and trying to do the radiation that way. I think the Cervaxin vaccine may be the most exciting thing in the last year or so. This is a immunotherapy vaccine against a particular protein which occurs in high-grade brain tumors, survivin. I can't believe somebody mentioned that, named it that. And actually, the vaccine seems to be very potent in getting a strong immune response to this. This just came out of phase 1 studies, on phase 2 studies in small groups, et cetera. And the early responses, looks promising that this may actually be able to build up a vaccine against that. Other vaccines are looking at, different sort of dendritic cell vaccines, oncolytic vaccines, which are viruses directly kill cancer. The idea of putting various radiation particles, chemicals, chemotherapies, and nanoparticles, these are super tiny, submicroscopic particles, and infusing them. The Day 101 study looked at a new drug for low-grade gliomas. Again, looks like it's some early promising response, etc. Stem cell transplants body don't work in this way because your stem cells in the is in the brain, body doesn't get into the brain. So when people looking, can you directly inject stem cells into these tumors? And do this kind of work. Nivolumab, for those who know anything about oncology, that's a common immune therapy drug now, which has been completely unsuccessful in this disease, but people are trying again, combining with other agents, try to break down the blood-brain barrier, try to do that. Carbon ion is a type of radiation. Carbon ion uses protons or a particle. Carbon ions are a very heavy particle, which releases a tremendous blast of radiation therapy. There are no carbon ion centers in the United States. There are, depending where you read, there are either 11 or 13 worldwide. The first one is being built by Mayo again, and will probably open in 25. And the idea is this intense but highly accurate radiation therapy can be delivered to these kind of tumors. We'll see what happens. And then artificial intelligence offers a lot about this. It does in all of oncology, all of medicine, by allowing us from the start to put together many of the little things that we've been talking about, the ideas together, and giving a really good model from the start of how this cancer is going to behave, how it's going to spread, and as you're aware, if you know anything about artificial intelligence, when you put these massive, databases in an artificial network, they can see things that physicians can't. They can see things that people can't. They can see patterns that people can't. And we're hoping just by putting this mass amounts of data into artificial intelligence, backbones, that they'll start to say, this is how you could treat this tumor, or this is a patient that is going to, have to get in trouble this way early on. They're going to get a blood clot because of this, or they require change in therapy because of this, and we maybe use this massive database, and as most patients in the United States gradually come on the same databases. I mean, New Jersey, within the next 2 years, 80% of all patients will be on the same computerized database, the Epic database, and that can use that, as a data source for intelligent, for artificial intelligence modeling, and therefore learn things about how to treat our patients, both predicting individual patients, but also, going forward. So these tumors are very challenging to treat. They're complicated to treat. But on the other hand, patients can do well, for periods of time. But it is important to have very realistic conversations with your clinician stuff, as you're making these decisions, going forward. Now, the other problem that occurs in the brain are not primary brain tumors, but they're metastatic brain tumors, cancers that spread to the brain. And again, we name these and we treat these from where they start because that's how they respond. A lung cancer to the brain responds like lung cancer, and it doesn't respond like a glioblastoma, a brain tumor, like a colon cancer. And the biggest group actually of tumors that are in the brain in general, actually tumors that spread, to the brain. So up to 20% of lung cancer patients, advanced lung cancer patients, not all lung cancer patients, advanced lung cancer will spread to the brain. 7% of advanced melanoma patients, 7 to 10% of kidney cancer patients, a sizable number of breast cancer patients, and an occasional colon cancer patients. Other cancers will spread to the brain in lesser amounts. Prostate cancer, when it spreads to the brain, it's like really rare. I mean, all of us have seen that only a couple of times ever. But all these tumors can, spread to the brain. And again, so if we have a patient that comes in the hospital or to a medical care that has not before, had any cancers, and they see a tumor in the brain, one thing we say is this start in the brain or to come from somewhere else? Some of the clues for that will be that often when a cancer spreads to the brain, other places, there'll be more than one spot. Another clue is that they're sharper defined, but there's a lot more swelling that occurs around them. And then, of course, if you find, if someone comes in and they have a tumor in their brain, you do an X-ray of their chest, and they have a tumor in their chest, that's a clue. Now, a decision has to be made about your treatment approach to this, and, if the tumors come from somewhere else, depending on what you know about the tumor somewhere else. You may treat these in ways that are not unsimilar to a primary brain tumor. They may require the surgery, particularly if it's an isolated tumor or a small number of tumors in a small area that are easy to remove. This may be a reasonable way just to be able to just get them out and be done. And doing so, of course, you get a biopsy if you didn't have a tumor somewhere else, but also relieve that pressure, et cetera. But from the start, you're staging these tumors, you're looking at, where this tumor is in the rest of the body, what the patient's general health is, and how they're doing. I mean, I've had patients who the only place that a cancer spread is to the brain, and we took the tumor out of the brain and they were fine. I mean, even years out, if it was the isolated, metastasis. If there are multiple different lesions in the brain, that may not be reasonable to remove them. It depends on where they are in the brain, how many, how large they are, what else is going on. Sometimes, not rarely, you'll have a tumor in the brain, but it's of a disease that responds well to chemotherapy. So if you have a small cell lung cancer or you have a lymphoma, those are diseases that respond very well to chemotherapy. So you may actually treat the brain tumor in the brain with chemotherapy or systemic therapy and be able to shrink it down in that way. Again, you're using steroids, you're suppressing seizures for brain things, depending on what is going on. But certainly surgical resection removal is thought of often. The other possibilities are instead of removing it, is you can radiate it. And as using stereotactic radiation therapy, you can actually radiate a significant number of tumors successfully and safely, because this computer modeling is so good about doing different sites. And using CyberKnife for stereotactic therapy or proton beam, you can radiate multiple sites. in general, someone has more, and they, it depends where they are, the size, the aggressiveness, but as a general rule, someone has more lesions, more than 10, then most people would, move towards, doing, whole brain radiotherapy. But again, that's part of treating the cancer, in general, and if you can get the cancer and the rest of the body under control at the same time, is often very useful to get the tumor and the brain under control, et cetera, because then, we have patients that continue to go on for significant periods of time, once you've gotten, that under control. So, this is a tough disease. It is a disease that obviously people have put a lot of thought and work to, over time. But it is a disease for, which requires expertise, requires conversation, and I think we all learn something year by year. Research continues to be really strong, and obviously, it's something we all hope the therapy gets better from going forward, and we'll continue to fight the good battle. So, thank you all for being here this evening. I mean, obviously, I'm more than happy to to answer any questions.
Yeah, Dr. Salwitz, thank you so much. This was so educational and empowering for so many people. We did have a question in the chat box from somebody who asked to please explain a cyst in the pituitary gland, and can it go away by itself?
So cysts, which are basically bubbles, right? It's like a balloon, a bubble. And we get cysts all over our body. Cysts in our kidneys, which up to 70% of people have, cysts in our livers. It's cysts, and you can get a cyst in your pituitary gland. The pituitary gland is the gland. It's a small gland right where my fingers meet in the middle of my head, right between my eyes and right down here. And it makes hormones. And you can make cysts in the pituitary gland, which are generally benign, not always, but almost commonly benign. And if they're benign and not causing any sort of malfunction, then they can be left alone. They generally won't absorb by themselves, go by themselves. They'll just kind of sit there and have to be monitored. The thing about the pituitary gland is a couple of things. One, it makes hormones. It helps control thyroid hormone. It helps control estrogen. It controls a lot of things. So if it's causing a malfunction, if this causes a physical pushing or a malfunction of the pituitary gland, that can cause hormonal malfunctions. And you may have to do something about this. And there are a whole bunch of medical syndromes that are related to that. And cysts can be surgically removed. Strangely, they actually go up through your nose to do that because it's right at the bottom of the head. They usually are not treated with radiation therapy, chemotherapy. Certain types of cysts can be treated with certain medications. They're somewhat uncommon, but they can occur. So once a cyst is there, it's probably there. Sometimes they have to be treated. Sometimes they can just simply be observed.
Thank you very much. Are there any more questions? I'm looking down here. You have some nice comments, Dr. Salwitz. So I just wanted to tell everyone that the program will be available in its entirety on YouTube. It will also be available on the library's health portal, just for the healthofit.org. And again, I thank Dr. Salwitz for his time. I know he's very busy, and most of all for his passion. He's given so much to the library and to our residents to educate people about cancer and to help people understand and make the best choices for their health. So on behalf of all of us, Dr. Salwitz, thank you. You are one in a million, so thank you.
It's my pleasure. 100%. It's always nice to be here.